Hi, this is Kert Viele. I'm a senior statistical scientist at Berry Consultants. This is the NHLBI ICTR webinar for March 2020. We're going to be talking about alternative endpoints. Obviously, an endpoint is fundamental to any trial. It's the headline, it's in the primary analysis. It's essentially what decides whether the trial is successful or a failed trial. The selection of a good endpoint is a very big topic, so we're not going to discuss all of this topic today. But I want to talk a little bit about how endpoints contain, what kind of information endpoints contain, and how we might find endpoints that are a little more meaningful, a little more sensitive, and allow us to have smaller trials or more informative trials. So whenever we develop therapies, we really want at least two things in an endpoint. We need them to be meaningful. So we want to be talking about something that matters. The FDA usually describes this as, in the guidance, how a patient feels, functions, or survives. So that would be a definition of a clinical endpoint. We also want those endpoints to be sensitive. So we need to be able to see differences in treatment. And a lot of times there's a conflict there. The most meaningful endpoint may not have the most sensitivity in order to tell that we have a treatment effect or not. So for example, this is for sensitive endpoints that are not necessarily meaningful. Many endpoints in early phase 2 trials measure the mechanism of action. So essentially, if a new drug is meant to change a particular protein level or a marker level of any kind, what we would do is we would measure that marker level in the phase 2 trial. And what we would do is we declare the trial successful if we could demonstrate that the marker was changed with the therapy. And so the reason we do that is we anticipate that we can get big effects with novel therapies, as long as they do what they are supposed to do. The difficulty is, the reason you may not get a meaningful endpoint this way is that the mechanism itself accomplishing it, it's unclear that that leads to good results for patients. Just because you're able to change this marker, you often have a hypothesis it will lead to good outcomes for patients, but you don't really have proof of that. And so an example of this is the amyloid hypothesis in Alzheimer's. So we often think, oh, if we can clear the amyloid, maybe we can help Alzheimer's patients. And that was a promising avenue. It's unclear as of this recording how far along that's going to take us. There's a lot of reasons to doubt that actually changing the amyloid may be too late in order to change the course of Alzheimer's, although at this point there is a possibility some trials have shown more promising results. So in the endpoint from the standpoint of the endpoint, changing amyloid in phase 2, it's not a feels, functions, or survives. And so what you really end up doing is in phase 3, you switch to an endpoint based on cognition or based on function. And so you've got this issue where amyloid is sensitive, but it's not actually meaningful necessarily, unless we could show it affects something that is. You can also have endpoints that are meaningful, but not particularly sensitive. Often mortality is clearly meaningful. It's probably more meaningful than any other endpoint. But the issue is that mortality differences can often be small between therapies. A lot of new therapies in sepsis, we're looking for survival rates to change by 5% or something in that ballpark. And those kind of changes require thousands upon thousands of patients to observe. And so it's very hard for us to design a trial that handles mortality in many cases. And we want to look for something that would let us conduct a smaller trial, but still retain some meaning. There often is a lot of meaning in therapies that is not captured by mortality. So for example, if you could, if there were differences in the time in hospital or the time on a ventilator, as opposed to just differences in mortality, that may also be meaningful endpoints, certainly fields or functions aspects of the endpoint. So as we go forward, what we're really aiming for is finding meaningful endpoints, but we want to capture all the information. So this kind of figure, you know, our goal here, we've got this big cloud of data that we've observed, or we're about to observe, and we want to retain all the meaningful information in that endpoint. But we want to, by retaining all of the information, we're trying to maximize our sensitivity. So we don't want to use something that doesn't have meaning. We don't want to use an unvalidated marker, but we'd like to be able to get, for example, more than mortality if there's something more than mortality in our data. Some ways that we often lose information. Dichotomization of endpoints is a common example of this. So a modified Rankin score, this is a measure that's often used, say, in stroke trials, used in other contexts as well. It's a 0 to 6 scale. 0 is essentially perfectly healthy or normal for that patient. 1, 2, 3, 4, and 5 end up diminished function. And finally, 6 would represent that the patient died. This is often dichotomized. So we would measure 0, 1, or 2 for a patient at the final analysis. When patient finishes, a 0, 1 to 2 would be a success for that patient, and a 3, 4, 5, or 6 would not be a success. And so this loses information, and it potentially loses a lot of information. So imagine, for example, you had a treatment that actually improved everyone's results by 2 points, if that's possible. So 6s become 4s, 5 becomes 3s, 4s becomes 2s, and 1s go to 0, and 0s, of course, wouldn't change because they already are at full health. But if I had a treatment that did that, and then what I did is I wanted to dichotomize it. So this 0, 1, 2 is a success. Any difference between the treatments, I will pay attention to the 4s becoming 2s and the 3s becoming 1s. And so I do that because I go from a failure, the 4, to a success, the 2. The 3 to 1 does the same thing. I get a failure to a success. So those are the kind of patients that would actually move that dichotomized endpoint. On the other hand, a sizable amount of my treatment effect just disappears. So all the 6s, the people who would have died that become 4s, they're a failure in either case. So the treatment, that improvement is ignored. The 5s to 3s are also ignored, and 5 to 3 on a modified Rankin is a very big difference. It's essentially a vegetative state to someone who can function with some help, but certainly can function. 2s to 0s are also ignored, and of course the 1s to 0s. So realistically, a huge group of patients is ignored. Their treatment effect, which is all meaningful and valuable, it's ignored by this dichotomization. So generally, you don't want to dichotomize. The underlying continuous variable, it is always going to be more informative. And so if that information is meaningful, you should be using the continuous measure. The 5s going to 3s matter, so you'd like to get those included. One of the reasons that the continuous measure is not used, there's often a discussion about the interpretability. And certainly if that's a discussion that's important, but again, you want to weigh that versus the information that's lost. The other thing that happens is continuous variables often do require more complex statistical methods. It's very easy to analyze the proportion of patients who are 0, 1s, or 2s, straightforward rate kind of calculation. Whereas using the underlying ordinal MRS scale requires methods like proportional odds or utilities in order to analyze. So, but given the extra information, it's worth considering using the continuous measure. Now, This is related to the amyloid discussion earlier. There are surrogate endpoints. And a surrogate endpoint is an endpoint that has actually been shown to predict a clinical endpoint. So in breast cancer, there is a surrogate endpoint. There's something called PCR, which is a pathological complete response. And this is this endpoint measures you essentially, a patient comes in with a tumor, you begin to treat them, and then some months later, what you do is you perform surgery and you remove whatever is left of the tumor, and you investigate basically what you've done to the size. Yeah, a PCR means that when you do this surgery, at the time you do this surgery later, there's no tumor left. So you can't find it anymore, would be a pathological complete response. Now that endpoint is by itself not necessarily a clinical endpoint. So if the tumor wasn't causing any feels, functions, or survives issues, we would still need to know that. But what has been done for a PCR endpoint is it actually has been shown to predict event-free survival. And so that's happened in multiple meta-analyses of patient-level data. And so that requires extensive effort in order to establish that. But once you have it, it's another way of getting a more sensitive endpoint. Also within breast cancer, PCR is observed far earlier than EFS. So not only are you able to make smaller trials, you're also able to make shorter trials and get good treatments to patients faster. An example of how PCR is important, the effect of PCR on survival depends on the exact type of breast cancer. But you do see dramatic effects. So for example, the hazard may be reduced by 80% if you have a PCR as opposed to if you don't have a PCR. So given the fact that we have this relationship that PCR, essentially you're expected to live longer with a PCR as opposed to not, then if you can show that you increase the rate of PCRs, then you should thereby increase event-free survival. And so the exact hazard change will depend on how much you increase PCR. So just a kind of example here, suppose that control has a 30% PCR rate and a novel treatment can change that to 40%. And these numbers it depends on the details of the cancer. These numbers are just made out of the air for example. But suppose the median survival is 10 years with a PCR and 2 years without one. This is that 80% hazard. If you can show that 10% more women get PCRs, and they're going to therefore get longer EFS on treatment, you can average these two numbers. So we know, for example, control, 30% are going to be in this 10 years, and the other 70% are going to be in the 2, whereas on treatment, that's going to be 40% on 10 and 60% on 2. So we can find the median EFS for each group, 2.92 on control, 3.41 on treatment, and that ratio is 0.86. It is much easier, smaller trial, to find this difference, the 30 versus 40%, than to try to assess the 0.86 hazard ratio. So this is the reason that people often prefer surrogate endpoints, smaller trials, and again, for PCR, it is a much faster trial. Mortality is another area where there's often more information about a disease process than there's more information in the data about the disease process than mortality itself gives. So this graph is not particularly exciting in terms of its graphs, but I'm trying to get at the notion. Remember when we did modified Rankin, we said the 5s versus the 3s, they were basically ignored. The 2s versus the 0s are basically ignored. You can imagine a disease process where people get sick, They end up in the hospital. A lot of times they might enroll in the study when they end up in the hospital, and they continue to progress in the disease. And you may have some patients that progress towards death, and certainly mortality will pick up those patients. But you may also have a large group of survivors, and a drug could have a meaningful effect on those survivors. So this might be what happens on control. You know, you get sicker and sicker, you do not die, and then you finally stabilize and improve, and you exit the hospital after a fairly long length of time. A novel treatment might arrest that, cause the stabilization earlier, and you might get out of the hospital sooner. So certainly the time in the hospital is a relevant endpoint. And this might be a way to get extra information out of the survivors. And certainly if you think that if you are slowing the disease process, you're likely to end up also changing mortality at the same time. So some examples of this. A rank composite endpoint is a way to try to get this extra information. An example might be some kind of treatment for premature infants. If they are very sick, mortality is certainly the most important aspect. But if you have a fairly large number of survivors, 15% mortality rate, for the survivors, you may be able to measure that disease process, or in this case, the development process, by using something like increased weight gain, which might be important in this particular context. If you want to do a rank composite, what's often done is your analysis first ranks all of the infants. So this is at the analysis. And all of the deaths, they're tied together as the worst result possible. And then the survivors are ranked higher than the deaths. So all the survivors rank higher than the deaths, but they are also ordered by their weight gain, lowest to highest. And so we've got kind of a graph of what this would look at. So the blue patients are controls and the red patients are on treatment. What we're going to do again is we're basically ranking all of the patients together. This may be hundreds of patients in the study. I've only drawn about, I think there are 14 here or so. But imagine there would be more patients. All of the deaths, these would be together. So here are 3 of the red patients died, 4 of the blue patients died. And so I've got a circle around them. These are all tied. So there's no discrepancy there. You could, in an oncology study, for example, rank the deaths by their time that they occur. But here they're all the same. And then among the survivors, what I'm going to do is I've tried to get this as a continuum, so that's what the shading indicates. And so this would be the survivor with the lowest amount of weight gain, and then on up to the survivors with the highest amount of weight gain. So the analysis would first do this ranking, and then it would try to basically say, are the blue patients doing better or are the red patients doing better? And so clearly you'd like to have most of your patients on this end and fewer deaths. This kind of composite endpoint, it allows you to have more information in the analysis. If I just looked at deaths, I would only be looking at this 3 out of 7 died on red and 4 out of 7 died on blue. That's certainly information. Blue has a higher percentage of deaths, and obviously imagine a higher sample size for a real study. But this also would combine that mortality information. We'd get information about the weight gain as well. So we'd be able to see that the red patients are, there's granted this low one here, but there's lots of red patients up near the top, and the bluer patients tend to be more down near the bottom of the survivors. So we also get to see that the blue treatment seems to do a little worse on weight gain as well. So if we combine this, then we're going to get more information. Now, it's possible that the deaths go one way and the survivors go the other, but often that just doesn't make scientific sense. If it does, you might want to consider something else, something different. So that would be a rank composite endpoint. Other kinds of mortality alternatives are something like hospital-free days. So, and hospital-free days, you can replace hospital with any other kind of term like ventilator-free days and so forth. And so this is an endpoint. It's similar in structure. It's usually defined as the rank composite. We have an endpoint that is defined at X days. So we often might look at hospital-free days and go out to 30 days or 60 days or 90 days. And the endpoint itself, this Y, this is the number of days up to whatever your X is. I'm going to say 30 just for an example, but the number of days up to 30 where the patient is out of the hospital. So if you're looking out to 30 days and the patient was discharged on day 5, then they've had 25, this should be a Y, 25 free days. In order to make sure that this endpoint incorporates mortality, if the patient dies, we assign Y equal to -1. So that's the worst possible outcome. It's lower than 0. So it's worse than being hospitalized the whole time. And also, if a patient is discharged and then rehospitalized, you don't get any credit for those out-of-hospital days. So if this were a situation where you discharged the patient on day 5 and they ended up coming back to the hospital on day 8 and then staying till day 15, you would only get credit for the day 15 on. You wouldn't get credit for that in-between time because they had to come back to the hospital. So this is to discourage people from discharging just to kind of try to win the endpoint, so to speak. You want to make sure you actually do have this person healthy enough to leave and to be stable after they leave. These are analyzed by a rank test. So again, it's the term rank composite. Typically, this is a Wilcoxon or its variants. A Van Elting test, for example, would do a stratified kind of rank test. So hospital-free days, this is going to retain more information, just like the rank composite that we saw. Remember, mortality, you either die or you live. It's just 0 or 1. And like the rank composite before, if you die for hospital-free days, you're a -1, but the survivors end up with this 0 to 30, just like the weight gain patients were lined up as well, and could be 0 to 60 or 0 to 90 as appropriate for the example. Typically, hospital-free days is more sensitive than mortality. It certainly incorporates the mortality information. So we do know how many patients died and lived as part of hospital-free days. It is more information. There is a statistical aspect to this. Analyzing a rate is done with a parametric test. Analyzing hospital-free days is typically done with a rank test, and non-parametric tests lose a little bit of power compared to their parametric alternatives. So there's this little bit of a trade-off where we're gaining more information, but we're using a slightly less powerful analysis. And I have an example, I think next slide, to give some numbers on this. But hospital-free days can require substantially fewer patients unless the effect is entirely on mortality. So let me switch here. Sorry, here we go. So this is the, oh, okay, I understand. So this is an example of a real trial. So this is the VICTAS trial. It is a sepsis trial investigating the Merrick cocktail. So this is a vitamin C, thiamine, and steroids together. There was a small observational study conducted by Merrick, which indicated a dramatic treatment effect on mortality. So, I mean, the mortality was pretty, less than 10% in the treatment group here. So this was a huge effect. A question has to be, is this a cure for sepsis? Does it dramatically reduce mortality? The difficulty is the trial was small. It's an observational study. Such trials are prone to potential biases. And so there are many doubts as to whether, first off, the effect is certainly that whether the effect is that large and whether there's any effect at all from this cocktail. So there's been many trials on this. There's been a couple large trials. VICTAS is the one that I'm describing here. There's another trial called Vitamins, which was published recently with their results. In the VICTAS trial, we are tracking both mortality as an endpoint, and this is a free day endpoint. The PVFD is standing for pressor and ventilator free days. So it's not getting out of the hospital, but you have to be off pressors and off a ventilator, and it's how long that happens. Same issue with hospital free days. If you're removed from the vent and then have to go back on the vent, then you don't get credit for the intervening days. So same kind of setup, but we're looking for freedom from a different, not hospital, but pressor and ventilators. The reason that both of these were tracked is the study team recognized that mortality is a standard interpretable endpoint, and so wanted to make sure that that was a part of the analysis, but also recognized that this pressor and ventilator free days is also meaningful and potentially retains more information because mortality is part of that endpoint. To give an example of the kind of trade-off here, when we were doing the power calculations for VICTAS, we looked at various changes in pressor and ventilator free days. So this is among the survivors, and the change in the mortality rate. And so this also gave us this is among the survivors. So let me make sure I say that correctly. So this is the difference in the survivors, the change in mortality, and of course, pressor and ventilator free days, that incorporates both. So if you had no change among the survivors, so you haven't done anything to help the survivors, but you've changed the mortality by 10%, you've dropped it. That corresponds to an average change of +2 days. Obviously, this requires some assumptions on how long people were expected to be on pressor and ventilators. If you only do a mortality analysis, then this is highly powered. So this -10%, mortality, just doing a proportion, you get 97% power. If you do a Wilcoxon test, then you only get 78% power. So this is where you would potentially take a loss from this endpoint. There's no change on the survivors. All of the information is mortality. So you'd really want to go ahead and do the parametric analysis. However, all of the other situations are heavily in favor of the rank. So if you don't change mortality at all, and you increase pressor and ventilator free days by 2.65 for survivors, that's also 2 days when you combine them. And of course, the power for the rank test is very high. And this is essentially the type 1 error because there's no difference. Similarly, if you have a combination, so this is a situation where mortality is changed by 3 or 6%, and the remainder of the effect is among the survivors, so that again, you still have this particular split, then the power is much higher for doing this rank test. So you can see the choice is really amounts to, if you think the entirety of the effect is in mortality, then of course you want to just analyze mortality. But if you think you have an effect in both of these, so I change mortality by something and I change survivors by something, then I want to incorporate both of those pieces of information, and I get much higher power from doing this kind of rank composite. To give more details, the VICTAS trial actually had some interesting ways that it handled both endpoints. There was a thought that if there was a huge mortality benefit, then we might be able to detect that with a very small number of subjects, so hundreds of patients, as opposed to the thousands that are typically in a sepsis trial. So VICTAS had a stage 1, which only investigated mortality. And it did group sequential interims at 200, 300, and 400 patients. and it only spent a very small amount of alpha. So only about 0.001 in terms of splitting for that stage. So this was all, this is going for home runs, very small amount of alpha spent. But for the effects that were seen in the Merrick study, if those were actually real, this is adequate to have very high power, 90% chance that we will actually detect even using this very small alpha. So stage one was, what if we actually do have a home run? If you don't have a home run, then there's a stage 2 to VICTAS. And so at n = 500, we're kind of entering the main design. There was some skepticism over whether we'd hit a home run. So this was viewed as where we really thought that we would find an effect. The primary endpoint is, this should be pressor and ventilator free days. Mortality becomes secondary at this point. So this is a predetermined switch in the endpoints. The interims are conducted at 500, 1,000, and 1,500. And at each of these interims, some of the data is incomplete. And so we ask 4 questions. And first one is, suppose we stopped now. How likely is it that we would win, and apologies, these should all be pressor and ventilator free days. How likely is it to win pressor and ventilator free days? And if we stop now, how likely is it to win mortality? And so that's uncertain because we have incomplete data. So we're talking about stopping accrual, following up all the patients, and then reporting the results. So we're saying, if we stop now, what's the chance we win each of those endpoints? We also asked the question that if we go to the end of the trial, which was at n = 2,000, how likely are we to win each of these 2 endpoints? So can we win them now? Can we win them later? And so VICTAS made decisions. If it was likely that we would win both endpoints now, obviously that's a happy situation. You're going to win pressor and ventilator free days. You're going to win on mortality. You're going to get the nice interpretable mortality endpoint. Everything's good. So clearly we would stop accrual, follow up the patients, perform the final analysis, and we're likely to get that strong result. It's also possible, because pressor and ventilator free days is so much more sensitive than mortality, we could be in the position where we think we can win pressor and ventilator free days if we stop right now, but mortality we don't think we're going to win with the data we have. And so at that point, VICTAS makes a decision, well, can I win mortality later? So in effect, I'll bypass this pressor and ventilator free days win, and I'll try to pick up mortality. This was done to try to essentially provide as informative an answer as possible. And the rule was fairly, it didn't take a high chance. If there was a 10% chance or higher of winning mortality later, then you'd continue the trial and try to pick up mortality as well. In order to have that 10% chance or higher, you did need to be seeing a positive mortality effect. If that wasn't true, so if you were likely to win pressor and ventilator free days now, but mortality was unlikely to win, then you would stop and take the pressor and ventilator free days, the likely win on that. And again, the notion is, I have that win, I'm unlikely to get anything better, and so that's what I'm going to report, what I can actually conclude. If I'm unlikely to ever win pressor and ventilator free days, then I would go ahead and stop trial for futility. Notice that pressor and ventilator free days is the primary endpoint, so we don't have the case. We considered it incredibly unlikely that we'd have a good shot at mortality, but not pressor and ventilator free days. This was a risk that was predetermined and decided we would take that. And of course, otherwise, we would continue the trial to the next interim. So if we have a modest chance of winning now, and we have a decent chance of winning later, we would just keep going and try to basically see what happens. So VICTAS is, it has completed its enrollment. and we are awaiting the results and publication. The summary here, so on endpoints, we've talked about a number of different possibilities. All of these are based on obtaining meaningful information from a data set. And really, while we've talked about a set of possibilities, really these are on a case-by-case basis. So we talked about surrogates, we talked about ranked composites, we talked about the possibility of free-day endpoints as an example of that kind of composite, showed an example trial, but there are lots of different kinds of possibilities. And again, the goal of this is to either shorten a clinical trial by getting more information or just to get more information for a given sample size. So thank you for your time.